Hello, everyone. My name is David Rue. I'm the Global Chief Medical Officer for Microsoft. What you just saw was a great video that describes a little bit about smart health cards. As most of you are well aware, this launched during the pandemic when there was a discussion around how individuals, consumers could be able to demonstrate in a secure manner and a private manner to individuals and organizations whether or not they were vaccinated, specifically for COVID. But what we've also recognized is that there's tremendous opportunity beyond that, where potentially leveraging the same open, secure, privacy securing, health equity ensuring standards that smart health cards are based on, we could potentially go beyond that. So today I'm joined by an all-star panel, many of whom have had tremendous experience with the smart health cards. And I'd like for each of them to provide an introduction on themselves, their organizations, and also a little bit about what they've been doing with smart health cards. So I'm going to start with you, Rebecca.
Great. Thank you. Good morning. I'm Rebecca Coyle. I'm the Executive Director at the American Immunization Registry Association. We are the association that works with all of the state, local health departments that implement an immunization information system, which is often the source of data for many of the smart health cards.
Good morning. I am Sandra Beatty from the state of New York. I am the first deputy budget director responsible for over $240 billion budget, including 113,000 state workforce. My role in the Smart Health Card is I also was a member of the Governor's Task Force on COVID Response and the executive sponsor and leader for development of New York State's Smart Health Card, known as the Excelsior Pass. So thank you.
Hi, I'm Neela McCare-Panani. I'm a practicing physician and clinical informatician with the MITRE Corporation, and I'm a member of the VCI Steering Committee. MITRE played a foundational role in bringing together this coalition around smart health cards and has also contributed to the specification development as well.
I'm Mickey Tripathi. I'm the National Coordinator for Health Information Technology in the Department of Health and Human Services. And what are we doing for smart health cards? The federal government is doing nothing for smart health cards. Well, the federal government does not require a vaccination credential. The federal government does not endorse a vaccination credential. So I want to make sure that that's clear from a policy perspective. However, I will say that one of the things that the smart health card has done has built on the standards that our office, the Office of the National Coordinator, requires that EHR systems support, namely FHIR R4. And so building on that ecosystem is something that that we're very encouraged about in any domain, in any value-added service. So that's sort of our interest is in making sure that whatever is made available by a state or in the private sector is done according to open industry standards and is done with appropriate consumer protections in mind.
Yep, thank you. And one of the real exciting things about the smart health cards is that it provides immediate impact and value to the consumer. And what we want to do is maybe just to understand a little bit more about how the smart health card works, because there's more than just a technology in play, and there's many different stakeholders. And so maybe I'll start with you, Nalima. If you could just perhaps share a little bit about that process for how does it start and where does the technology come in and who are involved in that?
Yeah, the very super simple layperson's explanation that I use for smart health cards when my parents ask me, what are you working on, is that it is a digital version of your CDC COVID-19 paper vaccination card that encodes the data in a QR code that can be scanned by anyone and also signs it so it can be verified. I think we have a slide here that gives us the higher level explanation of what happens with smart health cards. It is really a framework for transporting any sort of clinical data. It is not really COVID-19 or vaccination or testing specific. You can put any FHIR data in there, clinical information, as a packet that's wrapped in a verifiable cryptographic. You see here on the left, the issuer is the party that actually generates the verifiable credential and generates the cryptographic signature on it that attests that the data, clinical information in that credential is accurate to the best of their knowledge. That is provided or portable, so the holder or the consumer is the next person who gets it, and they can keep it as a QR code on a digital wallet, like on an application, a mobile application like Apple or Android, or it can print it out on a piece of paper, the QR code. and then they can share it with whatever third-party verifier that they see fit to share their information with, and that can be anyone. It's an open system. There doesn't have to be any pre-coordination between the issuer or the verifier. The data goes through the holder or the consumer, so they control access to that data.
Yeah, that's fantastic. And on the table or the chart there, it says digital or paper. And I want to talk a little more about this concept of health equity and ensuring that anyone can have access to that. Could you describe a little more about how was that incorporated into the development of the smart health cards?
When we put together the coalition, there were a couple of foundational or core values that we wanted to make sure that the specification and the product followed, including being an open standard, being privacy preserving, having a transparent development process, and of course equity. And one of the parts of equity is being able to support people who don't have a mobile device or have difficulty using their mobile device or just don't want to put their clinical information on a mobile device. And the specification itself is not US-centric, so we also have smart health cards deployed in a lot of countries outside of the US. So that was important to be able to make the paper QR codes a first-class citizen.
Yeah, and one other thing, it's also based off Smart on Fire. And we all know, we've heard of FIRE many times. Mickey, you were just mentioning it. Maybe just for the folks, just to make sure everyone understands, why is FIRE so important in terms of a standard, and how do you see this being potentially advancing as we think about healthcare interoperability?
Sure. So FIRE represents healthcare discovering the internet, and for us to be able to have interoperability in the ways that we're very well accustomed in almost every other walk of life. It's a standard that's that leverages what's called a RESTful API, which for those who don't know what that is, I assure you you do. Every time you open your phone and you open up an app for Twitter or Amazon or whatever it is you're using, there is a RESTful API in the background that is making that connection in a really easy, lightweight way, and that allows you to push information, allows you to query information, and it's very well supported across the industry, and almost every other part of the internet is the widely used pattern for exchange. So FIRE is now sort of the healthcare version of that. And from what ONC has been doing is having a path toward getting the industry to adopt APIs across the industry, and sort of transition the way we thought about interoperability to to get that across the industry. The industry is very fragmented, and so that's not something that happens overnight. So we started in 2015 with a regulation that required that certified electronic health record systems, which cover over 90% of providers in the country, and required that they implement what was called a functional API. And now this year, they're required to implement a technical specification, the FIRE R4 specification, which is exactly what the smart smart health card uses. So that's why we're very excited that that something that is getting traction in the market, that states have adopted as well as the private sector, is building on this ecosystem that we've been trying to sort of working really hard to create this open architecture ecosystem based on an open industry standard, and accomplishing exactly what we wanted to be able to have the industry accomplish, not just in this area but just in general, to be able to say we're going to just build apps on top of this open architecture ecosystem that we have now, and we're also going to do it in a way that is empowering the patient, allowing the individual to have access to their information and then use it in the ways that they find appropriate, rather than having an organization do it on their behalf.
Fantastic. And you mentioned adoption, and I'm curious now with regards to states, there were a lot of misperceptions or concepts being thrown around in terms of smart health cards and COVID passports, and I was wondering, Rebecca, maybe you could just share a little bit in terms of your thoughts in terms of what was out there. Was it accurate? Was it not accurate?
Sure. Thank you for that question. Well, first of all, if we could go back in time and scrub the word passport, particularly digital or vaccine passport, out of our vernacular, I would be very supportive of that. I think what it did is it really put folks on a path of confusing technology and policy. It's a difference between saying we now have email available, but we're going to say you can only send things through the post office forever and ever. And so we're actually seeing policies adopted like that across the U.S. The good news, though, is that over 30 states have adopted this, and we've got another 8 that are in the process of rolling this out through their immunization information system. I should also note, though, that it doesn't preclude a person getting the smart health card from their provider. Often the providers using their EHR are already connected to the IIS and are able to query and also receive that immunization data from the registry right back into their EHR, and that can also be put into the Smart Health Card.
Fantastic. And Sandra, in New York, I know you were one of the first states to be able to adopt. Can you just tell us a little bit about your experience within New York and how did that come about?
Sure. Building on a few themes that everyone has talked about here, first and foremost, the Excelsior Pass, the Smart Health Card credential, is at the individual option. There is no state that mandates, to my knowledge, Rebecca can correct me, but there is no state that mandates you use a digital credential. And why is that important? That's important to the equity questions that you were raising in the beginning of this conversation, that it is about getting and having the individual the choice to use paper or technology to have access to their own personal records. So that was at the forefront of when we first began with our vision of developing a Smart Health Card verified credential in the beginning of COVID, where we went from an idea to putting out the credential in lightning speed time for government and private sector and technology, which was around 3 months from beginning contemplating design, development, and rolling out onto the street for everyone, including the New York State native wallet, where we will be putting in other credentials in the future. But first and foremost, we always had the residents' privacy and security at mind at the foundation of this, and also ensured that we published and put out the credential in multiple languages. So that was something that was a foundation, and that it would be free. It would be free to the citizen, it would be free to the business. And the philosophy behind that was because New Yorkers, being at the forefront of COVID, we felt as the state government that our citizens and businesses had suffered enough throughout the pandemic, and they needed to get back to doing the things they loved. And at some point, we would be on the other side. And that was our guiding light of when we were in some of the darkest days of COVID and COVID response, was where would we be at the end of this pandemic? And how do you quickly get individuals back to doing the things they love?
That's right. And you had mentioned that this is something that you thought of across the entire state. Now, I know that many other states have also begun to adopt. And Rebecca, I feel like you've been able to see state after state make those decisions. Can you just share a bit more, like how has the adoption come across, and like where are we at and where are we heading in terms of adoption?
Sure. And actually, as Sandra mentioned, 3 months is lightning speed in public health for sure. Outside of responding to a pandemic that sort of emerges very quickly, I think implementing systems and solutions to try and navigate that often take many years. I think in terms of where we're at and in the implementation and rollout, if you think back to December of 2020, when the first vaccine started going in arms, we saw very quickly within a day that information was flowing from the office or wherever that person was receiving that vaccine to the immunization registry. That immunization registry was forwarding that on to CDC. And within hours, we had a national picture of what was happening. And so I think that didn't come just by chance. That came from a lot of years of trying to implement and work. Meaningful Use provided an amazing opportunity to be able to connect registries and provide that incentive to connect to the registries. And because of that infrastructure, we've been able to do that. Today, I think we're still faced with, public health has been chronically underfunded. It is only top of mind for exactly when the crisis hits, and then we sort of go silent for many years after that. So I think states are struggling right now to try and figure out, can we leverage our funds that we have right now? Keep in mind that it's not just funding, but it's also the human resources that are out there. Those human resources are the people that are responding, setting up clinics, managing data quality. They're doing sort of everything in the background. They're still in the response right now. And so while we know that many states are trying to implement smart health cards and consumer access as quickly as they can, they still have limitations because they have other jobs that they're really trying to fulfill as well. So it's happening. It's just not happening, I think, as fast as everyone would like.
Right, and then you mentioned states, was it 22, 30, somewhere around there, number of states?
We're up to 30 now that have implemented the Smart Health Card.
And the number of people this impacts, when you think about across the board, is like we have numbers that say about over 200 million. And it's not just the states. I think, Mickey, you had mentioned, and Nalima, about EHRs and how other organizations, maybe Nalima, can you just talk a bit more about the coalition VCI and who all has sort of embraced the smart health cards, and how has that coalition grown?
The coalition itself, I don't even know how many people, organizations, 800 plus, I believe, now are members of VCI. I'm being corrected, 900 plus. And the different organizations that have become members are sort of all over the board. I mean, this is probably one of the more diverse group of stakeholders in healthcare that we've seen come together like this. Some of the core organizations are obviously healthcare providers, large healthcare organizations, the EHR vendors, payer organizations, some health tech specific companies, but also technology companies that don't have much of a presence in healthcare. And of course, nonprofits like MITRE. I feel like I've forgotten some. We have private companies, CVS, Walgreens, commercial entities. So, this is a great group of stakeholders that's come together around smart health cards specifically to, learn more about them. We have regular meetings about it, and also to see if they can contribute by, making their own implementations here.
Yeah, I mean, it's amazing how many organizations have embraced the concept of smart health cards, and I feel like we've now given birth to this opportunity. But I guess one of the things that we've also seen is that the pandemic seems to be easing up throughout the country, and in some ways people may feel that smart health cards are no longer necessary, and perhaps maybe this is time to just move on. Mickey, I'm just curious in your thoughts in terms of, is that the case, or is this something that was just one and done and we move on to the next thing, or is this an opportunity that we need to embrace?
Yeah, and I guess there's two things that come to mind in that regard. One is we don't know that we're done, so we we should all just be prepared. The September will come, everyone will start going indoors, at least in the northern part of the country, and flu will start hitting around the same time, and we could be back to sort of seeing escalation in the virus as well. You're an infectious disease doc, you can tell us more about that. So I think we all just need to be cautious. I mean, the trends look really great. The fact that we're all here without masks mostly and feeling relatively comfortable about that, I mean, I think is, sort of, it didn't even look like that 6 weeks ago. So, I think that that's all great progress, but we always need to be cautious. And so having this capability and knowing that it can be available on demand, I think is really important. And that's why, something like 80% or, 200 million, whatever it is, of people in the US who have access to it if they want it is important. I think it's an important thing for us to sort of keep. With respect to the use for vaccination, let's just focus on that for a second. I think the international travel use case is still going to be here for a while. Things look okay in the U.S., and I think as we've been seeing, it's kind of a little bit of a global whack-a-mole kind of game, where things sort of go down in the U.S., but then all of a sudden things look really bad in Hong Kong. And and Hong Kong was looking at 0 cases, right, for a while, and trying to literally have 0 cases. So we just need to recognize that this is still probably going to be an international travel requirement in some way, and we certainly from the federal government want to make sure that individuals, U.S.-based individuals who travel abroad and who got the vaccinations here have the ability to do whatever they want to do in those other countries. And that's both entering the country, which is one piece of it, but also being able to participate in the country. I mean, we've had reports of service members, for example, U.S. service members who aren't able to go to an amusement park in Turkey, for example, because all they have is the paper CDC card. So we certainly want to be able to solve that use case. And I think that's why it's important for us to sort of keep in mind that there are still other use cases for the vaccination credential that are that are still important. One of the amazing things, I think, is that as we think about sort of international alignment around the different credentials, there's one from India, and there's the Green Pass from Europe, and there's the UK, and there's Israel, is Smart Health Card is at the table in those conversations. And I think if you look globally, the Smart Health Card is probably the only one that actually came from the private sector itself. All the other ones were created by national governments in more of a top-down way. Now, obviously, state governments played a huge role here with New York and California, but the private sector played a huge role here as well. And that, sort of distinguishes the smart health card, I think, and speaks a little bit to sort of the dynamism and, how things can work even in our fragmented world in the U.S., if the sort of the ecosystem is set up right. The last thing I would just point to is there's a lot of growth and outgrowth that can happen from this paradigm. So, the pandemic, I can kind of, in a way, gave us did us the service of being able to help us leapfrog a certain bunch of things. And now we have this model of, wow, I can have something embedded in a QR code, and I can, kind of use that in different places. And that interoperability seems to work. And maybe that's a pattern that works for individuals as they think about their healthcare information. And maybe we can start thinking about other types of information. Like in New York, they put test information, test result information in there. What about my demographic information? What about my insurance information? What about my consent information? What about my representation of my race, ethnicity, language, for example? You can imagine all sorts of other information, being there. You can certainly tell us about, well, you can't actually cram all of that into a, I don't know what it is, 232 by 232 QR code, but there are ways using, secure URLs and other kinds of things to have a lot of information there. And I think that's now the opportunity that we at ONC are certainly looking at to say, that's a really cool paradigm. Are there ways for us to build on that, that would offer a better customer experience for patients?
Yeah, and you mentioned New York, and Sandra, I want to ask, so it was not just vaccine status, but also test results. Can you talk a little bit more about kind of the thoughts behind like why you wanted to include more, and are there plans and thoughts about even expanding?
So for COVID specifically, because the New York requirements had a testing proof and also a vaccination proof for certain venues, we designed the Excelsior Pass to have a testing credential and also a vaccination credential. So those are readily available for individuals who are vaccinated and or tested for COVID in a New York State-based laboratory. Obviously, with rapid tests and the mailing of home test kits, that introduced a different layer of public health information that no one has any idea about the results of that. So that is what we have for COVID currently. We are also working on non-health use cases for going into the New York State native wallet and starting to explore moving into immunization records that are required for P through 12 school education as well. Because, we always think about it from the perspective of our citizen. Whether you are a soccer mom with 4 children and you're trying to keep track of the immunization records, or you are someone who cares for elderly parents, the technology and what we have designed, that primary caregiver can have all the family information right there for ease of mind. So that is where we're at. I think some of the things that, when we talk about what's next as a nation, we were all rallied around the common goal of fighting COVID. We will never have that, and I worry about the splintering off that will happen in this sector without a national framework of prioritization for what else should go into the smart health card credentials. And on all the international travel that we have had multiple conversations with states, individual countries, working on so that New Yorkers could fly seamlessly before the international community rallied around standards. But with that, we are running into roadblocks based on the nature of no state or no private entity is the national federal government. So I don't know how far we will be able to go on the international travel. We will continue to push that conversation, have a joint seat at the table with the partnership that we all have through VCI and our individual powers. But that is what we're working towards on that international front. I think this is a case where the technology is easier than the policy. And that is why you are also seeing the slow adoption across the United States. But I would say in New York, in under a year, we have over 10 million citizens who trusted the state to have develop and have access to these records. That is extraordinary. And how do we all, as a society, preserve that trust, particularly around data privacy in the healthcare records? I think the interoperability nature that we all collectively on this panel and the 900 so organizations that rallied around, how were we going to seamlessly do this? If we did not have that, if folks bring yourself back to, if you travel by car and the early adoption of Easy Pass, and you could not seamlessly go between individual states, we overcame that by collectively coming around these standards. And I would say that the maturity that came out of Mickey's organization with setting that framework created the backbone for us to all collectively do this.
Yeah, and having recently moved to New York, I can tell you the Easy Pass is amazing. Definitely. As we think about different types of adoptions and variations, Rebecca, I'm curious, because New York had their own journey, and other states have gone through maybe slightly different journeys. Can you just talk a little bit, how are other states adopting smart health cards, and are they all using it in the same way?
So pre-pandemic, there were a number of states that already had implemented something we call it consumer access. So it's the portal for individuals that live in a jurisdiction to be able to access their immunization information directly through a user interface. So there were about 15 states that had either started that process or had something in place to be able to provide that to their citizens. That certainly has grown. We now know that over 30 states have adopted smart health cards and are working on providing that directly to their citizens. So I think this has really sort of created that consumer demand. In public health, you sort of have to strike while the iron is hot, while there's funding available, and you just have to move forward as quickly as you can. So I think consumer access has been a sort of gold standard in where we really want to go, providing access, transparency. Citizens need it. Everybody needs access to their own information. I think that in and of itself helps build trust in government and organizations. But the resources were not available prior to COVID. And so this is actually accelerating that. I think the policy challenges existed before, and some are more challenging now while others have been sort of removed. It's just different policy challenges. And I think, something Sandra said earlier about policy being the barrier. Policy is almost always the problem in our situations. It's rarely the technology that's the issue. You can solve all kinds of problems, but unless you have the policies to support it, it becomes rather challenging. So I would say this is another example of where we're creatively trying to solve this in a way that benefits citizens.
Yeah, that's fantastic. Now, I want to maybe play devil's advocate and think of perhaps an organization or a state that says, I think you guys have just over-engineered this. Nalima, what are your thoughts? Have we over-engineered this, or is there actually some significant value that maybe people aren't recognizing?
Yeah, when we approached building the specifications for the smart health cards, we deliberately tried to make it reduce complexity as much as possible because we were aiming for speed of implementation and scale of implementation. So the data requirements for the clinical information in the smart health card are very minimal. The infrastructure requirements are also very minimal. So I would say there was a focus on not over-engineering it right up front.
Yeah, and really, we're now giving consumers the ability to have access to their health record, which is amazing, because if you think of the vaccine status, the test result, this is part of your health record. We're leveraging the same standards. We're ensuring that there's health equity. I just know that this has been a major area of interest in terms of a lot of the states adopting this. So I want to pause now and see if there's any thoughts or questions from the audience. Maybe just take a few moments, and if you do, just please raise your hand. We have a mic that we can walk around.
So with the focus on interoperability and payers and providers and others opening up FHIR APIs, is there a reason that we didn't also create a mandate for APIs for vaccines and rather going through the smart health cards, so that as consumers are aggregating all their healthcare data in one place, that this is not yet another separate fragmented experience for them?
Yeah, so I can start. And I guess, at least the way we looked at it is that your vaccination record is just a part of your medical record. It's not, so when we were in conversations with other federal agencies, we were like, this isn't there's nothing unique or different about this. This is just your medical record. And we've been doing everything that we can with respect to interoperability to say patients have a right of access to their information, and we should be putting the technologies in place and requiring the providers and the technology vendors support patient access through APIs, through FHIR APIs starting this year. And so this is really just a piece of that. It's not any different. So I guess I'm not sure I fully understand the question, because
Sure.
in a way we have enabled that. We've basically said the APIs are required to support that, and this is just one particular way of having that represented in a way that allows scalability. But the basic construct of an API that allows you to get your vaccination information is a part of everything.
Well, except for the fact that there were mass vaccination sites, and so very few vaccination records, well, I don't want to say very few, some of the vaccination records are coming through the clinical APIs, through health systems and others, but the vaccine registries, which sit inside the states, are now participating in smart health cards, but they are not opening up APIs to patient-facing application integrators.
That's not entirely true in every state, because in New York State, the majority of New York residents or citizens were vaccinated at state mass vaccination site. Those records are all directly into the immunization system. When the federal government started to open up the pipelines for the COVID vaccine that was sent down to the state and local governments, the pipelines expanded. So then you started to have mom and pop pharmacies, national chain pharmacies, the pediatric, the hospitals. All of that information rolls into the state's existing immunization system. And Rebecca can talk more about that. I think what, and you all can weigh in on this, I think what happened is COVID and this COVID response exposed that the immunization records at the states need to have some data cleanup. We exposed and did a lot of data cleanup to ensure all of those pipelines from providers within the state were working actively through the existing APIs, and that the data calls were pushing back and forth within the time constraints that the state and or through our regular regulations or through our emergency COVID regulations required. So I think there's an active management part from the state level and also the federal level to ensure that the processes that were already there in place, that they're all working, right? Because these immunization systems, every state has them. And I'll tell you from talking to my peer states throughout the entire journey of COVID, you know, the Northeast region states, I've participated 3 times a week for over 2.5 years with the Northeast Coalition calls. And we all speak about the importance of the state immunization systems being accurate. And that accuracy is dependent on public-private partnerships and all the different channels of where individuals are free to receive their health care, that they're working correctly and as they're intended to do. I think the one that was the hardest for us and hardest for our peer states within the Northeast region were those who were vaccinated at federal institutions. And this is not a mock at Mickey, but it's just the difference of how the federal government systems were set up and how that information flows or does not flow into the state immunization records.
And I think if I understand your question that you're getting at, are you asking, why don't you just open up every IIS so that everybody can access that and be able to get that information? And the short answer is policy. And it depends upon the state. So some states have allowed that to happen. A consumer access portal often uses that very same technology. Again, it's just not available in every state. And there's also, you know, sometimes the state legislation will specifically call out who can or who cannot have access to the data. So you have to navigate those pieces too, which is why it's not uniform.
But that's 30 states now, right?
Right, that's 30 states that have adopted it, and hopefully
Right.
there's more. And there's still some that have consumer access, but maybe don't have a smart health card enabled because of legislation that
And
prohibits
it
it.
is really heterogeneous and spotty. So I have 3 smart health card credentials on my phone. I'm happy to show them to you. Each of them, I got 2 of my vaccinations at a mass vac site at Gillette Stadium, and then 1 from CVS. My provider didn't do any of them, but I got my first credential from my provider who had all of the vaccination information, and they were happy to give me a credential as well. So I got a credential from the provider, I got a credential from CVS, and I got a credential from the immunization system in Massachusetts, all with the same information 3 different places. So there are some places where you can get that information. It is flowing in the background, and you have multiple, sort of front doors to be able to get it.
Yeah, I mean, that's what I'm saying. It's very fragmented today.
Yeah.
And so for consumers that are really trying to collect and aggregate all of their information, New York is an exceptional standout. There are places in the country that absolutely are. But if we're going to have these states implement and open up data to the smart health card, they could also be mandated, just like information blocking handles clinical and payer, to open up APIs for that vaccination information as well.
Yeah, there's the 10th Amendment to the Constitution, which is which is a big policy issue.
Yeah, and I would say when you sit at the highest level of being a policymaker, you are responsible for that citizen's information. That it sounds much easier if you're a vendor or you're a provider or you're a consumer, but it's not easier if there is a breach of the system and you're responsible for all of that information. So it has to be carefully and thoughtfully discussed and worked through, which I think is something we all spoke about yesterday when we talk about what's next, right? And what's next, and thinking about, and Mickey was making points yesterday around the difference between the data privacy, the data security, and the importance of that as you move into different levels of health information.
And just to clarify, EHRs can actually access the immunization information systems in every state. And so they are pulling that information over. Oftentimes, that's exactly what's seeding the smart health card, particularly for COVID, where the vaccines were administered elsewhere. And that exists for all immunizations, not just for COVID vaccines. I think we're just starting to see it. But you're right, there's absolute fragmentation, and we hope to get to a more streamlined rollout. I think the more you do it, the more people become comfortable with it. And I think we're going to see that ease and that adoption over time.
Yeah, I would have a comment. I think a lot of the questions I had, I already have the answers now. I think I got my smart card from my provider. When you have an access to a provider who is technically savvy and has the right EMR, it's much easier, but that's not the case across the country. And the issue is that, like I'm a former CIO of a health system, work for a vendor. Dr. Drew and I had a pleasure of talking at a couple of events last year. We developed a vaccine administration solution for a county. And the back-end work required to get the data from the vaccination system back to the registry, that a lot of work. We spent months and months making that work. And the states were very cooperative and accommodating in terms of, in one case, state of Texas, we decided to have the county's EMR connection to send our vaccination data, so that we don't have to build a brand new interface and go through the validation and all that. That saved a lot of time, and we were able to report to the registry. But the one negative thing with the FHIR-based integration is that when I go to the doctor, I can ask him to download the information from the registry and put it on my smart card. It is not a standard practice that they download it for every customer. Like my wife doesn't have the smart card because she has not gone to a doctor after that. So that process is still kind of disjoint in the sense you are still dependent on your primary care physician to get it for you, which is the case with the childhood immunization and all that. We are used to that. But with the smart card, people's expectation has changed a little bit. And I think we have, and like I mentioned, the HL7 interface, behind the scenes we did with the county. A lot of people don't understand with FHIR everything should be magic, but it's not really magic.
Yeah, I mean, to Rebecca's point that, there's technology, there's policy, I would say there's also culture. And there's culture and norms and customer experience and customer service. So in my case, I didn't ask my provider to go and get that vaccination information. My provider just does that. They see that as a part of their duty to go out and get all the other information that they can find on me. What's that?
When you are visiting the provider, because there is not a back-end process to say, I want to download all the vaccination for all my patients every day.
Well,
Well, my provider has a connection to the IAS system, and they regularly go and get information out of the IAS system on their patients.
I think what you might be getting at is sort of that bulk. If you have a lot of patients that you want information for, you want all of that information. So that there are absolutely some I won't say challenges. There are solutions in the works right now, but essentially we all have to agree how we're going to operate. What are the rules of the road? who's going to be responsible for this piece. So that's in process right now. We're working across, well, I don't see as many folks in this room, but across a lot of the organizations that are here, at this meeting, to try and solve those problems, because it's got to start from, I think, the ground up and sort of look at every use case. Let's make sure that we're solving this for everyone, or as many as we can get in the room, not just one and done, and then we repeat the problem again. And then just one other piece I wanted to mention, I think the patient component. So there's a very large EHR that has started providing sort of the consumer ability to query the IIS, and it's currently just for COVID. So you can go into the patient portal. If that vaccine is not available, it then allows you to say, let's check the IIS. You can click that button, it will go out, search for that record. If it's still not found, then there's a new process that's been implemented, and this has been fabulous because I fit in that category of my records are not in the registry because I'm in a clinical trial, not because I didn't, because they didn't send the data, they just can't yet. So the process that they then followed was, enter your information, all of the information, send us a copy of that, and we will validate that, which would be no different than me walking in there and presenting the same information. I have a Smart Health card that has all of my COVID vaccines on it today because of that process.
I guess one other thing I would add, since you're on fire, I think some of what Rebecca was referring to, there is we've launched with the CDC a fire accelerator called Helios, and one of the use cases they're looking at is the use of what's called bulk fire. So it's basically the ability to send a roster of patients to the information source. In this case, send a roster of patients, like my patient panel, for example. Send that to the immunization registry, allow them to do some background processing of that information, and then push it back via a FHIR API. And again, the technology, is not the issue here. It's, sort of policies on how would I actually communicate a roster? How's the IAS system know to trust that roster? All of those, kinds of issues. But the bulk fire specification is ONC requires that EHR vendors implement a FHIR API, both for an individual patient as well as for the bulk fire API this year.
All right, fantastic discussion. Wanted to maybe move to we'll call it a rapid fire or lightning quick session where each of you, I'd like to get your thoughts. And we've talked about the benefits of smart health cards for now and potentially then beyond the pandemic. We haven't quite gotten as high a level adoption as we'd like to, and there needs to be more investment into this. And wanted to kind of get your thoughts in terms of maybe name 2 reasons or ways that we can invest in smart health cards and increase the adoption and go beyond COVID. So again, I'll start with you, Rebecca.
Thank you. So I will start by saying data quality, which I don't think we've talked about yet. I think data quality is key. So if you now have the ability to take all of that information and show that to your provider or whomever else you choose to show that to, you are no longer having to hand key all that information again. So I think data quality, data quality, data quality. And then I think the other piece is that, we could have been more prepared for this pandemic in a lot of ways. And I think we have to remember that everyday readiness is really pandemic preparedness. And so the more we practice, the easier it's going to be when there's a time to actually exercise all of this at full capacity. So I think there's a lot of utility beyond this in the data quality, but then also getting us ready for the next emerging piece. And then I'm going to add a third. I think it's also being, using it for those routine opportunities like school and childcare enrollment, day camps, international travel. I think there's a lot of utility long beyond this pandemic.
Yeah, Rebecca, data quality, I cannot tell folks how much, even the state the size of New York, how much time we spent on ensuring the data quality and data cleanup before we rolled out the Excelsior Pass. So there's much there in the friction of how do you get clean data. I think 2 things. One, COVID and the pandemic has now elevated public health into our emergency management discussions. Although the states previously had dealt with influenza, other Zika, Ebola, you name it, they were never at the level that COVID was and that it impacted every single state. So I think I'm optimistic that funding will improve, similar to what we saw after 9/11 with the creation of Homeland Security funding. So that, I think, on the funding side is something that will be helpful for the public health community and going into the next pandemic, hopefully we are not all here for it, um, is I think something good that has come out of this, right? The public health is now starting to be in the dialogue, in the stovepipes of the Department of Homeland Security and others. So that is something good. I think the other thing is there is a lot of fatigue in the state and local health departments and in the medical community. And that fatigue is not to be undersold for what we need to move forward on the next steps of any sort of immunization or smart health card response. And we need to ensure that those who were there in the front lines of COVID response at many different hats and levels of government, public, private sector have some sort of lessons learned, and we capture that information before people retire or leave the workforce altogether. And I think those two aspects, the first being that COVID elevated public health into the emergency management nomenclature is a good to come out of this. I think the other thing is, to the extent we can document all of these lessons learned and use those in our next step in preparedness would help all of us.
I think first, I think the Smart Health Card is a great introduction or first use case for consumer access to data. And Mickey alluded a little bit earlier to an extension to Smart Health Cards that's in the works that we're just starting to get to, Smart Health Links, that will help us transport all kinds of different data beyond vaccination, COVID testing, and larger payloads. And this will build on top of what we've done so far with Smart Health Cards. So I think we want to keep heading in this trajectory that we've started on and not lose the momentum we've made so far with consumer access. And then I know several people have alluded to being ready for the next pandemic. And just on a personal note, as a hospitalist, I've seen firsthand the human cost of this pandemic, not just for the COVID patients, but really everyone that we treat in the hospital. And we've had patients with the elderly patients with dementia who are in the hospital or they're afraid and they can't have family at their bedside because of visitor restrictions. And just imagine a scenario where that family member could provide verifiable proof of their vaccination status and a negative lab test in the last 24 hours. That could be a real game changer. So I think just thinking of the human cost, we want to be ready to prevent these scenarios when the time comes next time.
Yeah, I guess I certainly agree with everyone. I'm the last one, so everyone always gets all the good ideas. I had a couple of things just building on this consumer access piece. I mean, I think that why invest or continue to invest in in this? I would just say that it's investing in innovation on the open architecture. So to the extent that you are going to make investments in healthcare, investing in the open architecture ecosystem both serves you better because you're sort of able to scale and able to have those capabilities, and it helps to contribute to the momentum that is self-reinforcing. The open architecture ecosystem starts to support itself as more and more people participate in it and think about the innovative uses. So that little QR code that is just for the COVID vaccination status, as I said before, what other kinds of information can you put in there that start to solve both medical problems, clinical problems of the sharing of information, but just basic administrative, sort of convenience and customer service problems. There's a reason that hospitals invest in valet services, for people showing up because people want customer experience. They want customer service. And, we're really behind in healthcare with basic customer service as it relates to just the basic stuff of providing my information, to have the no more clipboard phenomenon that, we've been talking about for 20 years. And we still, even crossing hospital departments, we're still filling out paper forms, going from one department to the other. If this is a way of, sort of helping to solve that, and, using that as a sort of a launching point for other kinds of capabilities, I think it's sort of a great vehicle that we hadn't thought of before the pandemic, and now is an opportunity for us. Building on FHIR, the other thing that we did some work on behind the scenes, we haven't talked about it, is scheduling. There was a big issue with vaccines.gov and how do we have better, more uniform scheduling, and we work behind the scenes with a number of organizations, retail pharmacies, provider organizations, and others to say, if you build this on the FHIR scheduling resource and the FHIR scheduling framework, that'll give the opportunity for scalability in the future. And we had a number of organizations that behind the scenes actually implemented a stripped down version of the FHIR scheduling implementation guide. And And that, I think will serve us very well as we think about the future post-pandemic of, why can't we have more kayak Expedia type of experiences in healthcare so I can go and schedule where I want to be able to schedule. Again, that doesn't happen overnight, and there's a lot of policy that has to happen, but at least building it on the rails, the chassis of this open architecture ecosystem is, one of the things that we've been promoting, and I think we've seen a lot of really good use cases that have come out of the pandemic.
Wow, what a great discussion. So many great points. I'm going to highlight four. First, that smart health cards are open. It's not proprietary. It's something that we have found to be an essential principle. It's interoperable, leveraging FHIR, a known standard that is widely adopted within the electronic health records and the healthcare space, and now has the ability to expand beyond what we currently see with COVID vaccinations. It addresses health equity. It's both in digital and paper formats, so it's something that anyone can use even if they don't have a smartphone or if they choose not to use it in a digital format. And it's privacy preserving and essentially allows the consumer to be in charge of their own health, which is what we are trying to get towards, where consumers are becoming much more the driver as opposed to the passenger. And so I'd like to thank the panelists, again, an all-star group. Fantastic discussion, each providing their own insights. I'd like to leave you with perhaps some maybe takeaways. If there's an opportunity for you to participate in the things that we have talked about and would like to be an active member, VCI is free. It's something that you can sign up for, and Heather Mitchell, who is right over there, can help provide more information. You can also go onto the website. I'd love to be able to continue this conversation with y'all, but unfortunately we're out of time. Thank you. Have a great rest of the conference. And again, thank you for your time.